Examination of thoracic and lumbosacral spine. For general inspection, look for the gait once the patient walks into the clinic. Note any deformity, abnormality of posture or motility. Ask the patient to take off the clothes. Then, look for scars, Kiefer-Ole spots, hairy patches or fat pads as well as any lumps and bumps. Observe for normal contour of spine. Palpate for area of tenderness. Pain reproducible on palpation of the spinous process may indicate a problem with the vertebra, for example, a recent fracture. Pain palpated on the paraspinal region may indicate muscle cramps instead, especially if tense back muscles are present. After inspection and palpation of the spine, we can proceed with the Adams test. The principal screening test for scoliosis is the physical examination of the back, which includes the Adams forward bending test, while the scoliometer quantifies the trunk deformation. The scoliometer is used at 3 areas of interest: at upper thoracic, main thoracic, and the thoracolumbar area. Scoliometer measurement equal to 0 degree is defined as symmetry. Any other scoliometer value is defined as asymmetry. Active range of movement. Thoracic extension. Patient prone with hand claps behind the head. The head and upper trunk extending off the table from about the nipple line. Patient extends thoracic spine to the horizontal. Lumbar extension. Patient prone with head and upper trunk extending off the table from about the nipple line. Patient then extends the lumbar spine until the entire thorax is raised from the table, clearing the umbilicus. Grading for thoracic and lumbar extension. The grade 5 and grade 4 tests for spine extension are different for the lumbar and thoracic spines. Beginning at grade 3, the tests for both levels are combined. These are the muscles involved in thoracic and lumbar extension. Trunk flexion. Trunk flexion has multiple elements that include both thoracic and lumbar motion. Patient supine with hand claps behind head. Examiner stand at side of table at level of patient's chest to be able to ascertain whether scapula clear table during the test. Next, trunk rotation. Patient supine with hand claps behind the head. Patient flexes trunk and rotates to one side. This movement is then repeated on the opposite side so that the muscle on both sides can be examined. Passive range of movement for thoracolumbar extension. Patient lies prone with arm crossed and head resting on the hands. Use the crossed arms to pull the patient's trunk upward. Flexion. Patient supine with hands clasped behind the head, standing at the side of the table at level of patient's chest. Use the clasped hand behind the head to pull patient's trunk upward. Rotation. Patient is supine with hand clasped behind head. Use the clasped hand behind head to flexes trunk and rotates to one side. This movement is then repeated on the opposite side so that the muscle on both sides can be examined. Next, functional tests for range of movement. Further provocative tests and maneuvers may be carried out to determine normal or abnormal spinal movement and function. We can use back range of motion instrument, BROM2, that can help accurately measure the range of motion of the back. The flexion extension unit is a modified inclinometer that eliminates the need to measure sacral flexion. Place the BROM flexion extension unit on the sacrum with the pivot point on S1. Have the patient stand erect. Feet should be shoulder width apart. Place the movable arm on T12 and record the reading on sliding scale. This reading is the distance between T12 and S1. The typical reading for an adult is 15 cm. Lumbar extension. Patient is standing erect. Place the arm tip on T12 and record the initial reading. Replace the arm tip on T12 and record the full extension reading. A typical value is 12 degrees. Lumbar lateral flexion. Place the BROM right and left unit so the unit feet is in line with T12. Place the thumbs over the back of the unit's feet and grasp the rib cage with the fingers. For right lateral flexion, slide right hand down the side of the leg with the body shifted to ipsilateral foot and keeping the leg straight. Record the reading. Typical value is 25 degrees. Rotation. The compass on the brom right and left unit measure to the magnetic reference placed on a selected spine location, thus eliminating unwanted spine movement below that point. Have the patient sit erect. Feet should be flat on the floor. This position will stabilize the pelvic area. Arm cross over the chest with hand placed on the shoulders. Palpate and mark S1 and T12. Place the belt in between S1 and T12. Place the magnetic reference over the sacrum. Have the patient slowly turn the shoulders to the right, making sure they go to full range. Record the reading. Typical value is 10 degrees. Schober's test. Classically used to determine if there is a decrease in lumbar spine range of motion. Patient is standing. Examiner marks both posterior superior iliac spine and then draws a horizontal line at the center of both marks. A second line is marked 5 cm below the first line. A third line is marked 10 cm above the first line. Patient is then instructed to flex forward as if attempting to touch his or her toes, while examiner remeasures the distance between the top and bottom line. This gap between the two marks, which is currently 15 cm, should increase by more than 5 cm. Anything less than this indicates reduced lumbar flexion. Examination of thoracic and lumbosacral spine following specific spine anatomy. The sequence of examination should be started from skin, muscle, ligaments, facets, bone, disc, and nerve roots. For the skin, we can check the surface anatomy as you can see in the diagram. For muscle, we should check the back muscle, then test for weakness, especially on the large back muscles. With patient prone, ask the patient to arch the back and rock on the stomach. Inspect and palpate the paraspinal muscles. Next, we check the hip adductor muscles using Trendelenburg sign. The patient is asked to stand on one leg for 30 seconds without leaning to one side. The patient can hold onto something if balance is an issue. Observes the patient to see if the pelvis stays level during the single leg stance. A positive Trendelenburg test is indicated if during unilateral weight bearing and the pelvis drops towards the unsupported side. For ligaments, we can do Yeoman's test. The patient lies prone, the examiner stands at the painful side and flexes the patient's knee to 90 degrees and extends the hip. Pain localized to the sacroiliac joint indicates pathology in the anterior sacroiliac ligament. Anterior thigh paresthesia may indicate a femoral nerve stretch. Other than that, we can perform sacroiliac compression test. The patient is on his side, lying, and the examiner's hands are placed over the upper part of the iliac crest, pressing toward the floor. A positive result is indicated by pain or replication of the patient's symptoms. To check for facet, we can do CAM test. Patient is standing, fixes the opposite ilium from the side, being tested with one hand. The other hand grabs the shoulder from the patient and leads the patient to extension, ipsilateral side bending, and ipsilateral rotation. Hold this position for 3 seconds. The test is positive when the patient reports pain, numbness, or tingling in the area of the back or lower extremities. Local pain suggests a facet cause. For bone, we can check interspinous space by doing interspinous gap change test. Patient stands with feet shoulder width apart, asked to flex his back with both hands on the edge of examination table. At flexion, inspect gaps between interspinous space. The test is positive if the width of an interspinous space abruptly becomes narrow compared to other interspinous process or changing position of upper spinous process anteriorly or posteriorly from the original state. For this, we can do the reverse SLR test. The patient lies prone, the knee is flexed, and the examiner pulls upward on the ankle while pushing the buttock forward. With this disease, there is pain in the back or in the femoral nerve distribution on the site of the lesion. SLUM test is used to assess lumbar radiculopathy due to disc herniation in patients with low back pain. Patient is seated with hands behind the back to achieve a neutral spine. Have the patient to slump forward. If this position does not cause pain, ask the patient to flex the neck by placing the chin on the chest and extending one knee as much as possible. If extending the knees does not cause pain, ask the patient to actively dorsiflex the ankle. For nerve roots, it can be assessed by using dermatome and myotome following the American Spinal Injury Association ASIA chart. Nerve root can also be examined using straight leg raising test, as it remains the mainstay assessment in detecting radicular compression. The test is performed by slowly raising the symptomatic leg with the knee extended. During SLR, tension is transmitted to the nerve roots between about 30 and 70 degrees. There are various degrees or levels of positivity. Ipsilateral leg tightness is the lowest level, pain in the back more significant, and radiating pain in the leg is highly significant. Lastly, we finish our thoracic and lumbosacral examination by testing the reflexes. Reflexes can be divided to deep tendon reflexes and superficial cutaneous reflexes, which can further divide it to superficial abdominal reflexes and superficial reflexes of the lower extremities.